Upper gastrointestinal bleeding. Upper gastrointestinal, UGI, bleeding refers to bleeding that occurs in the upper part of the digestive system, specifically above the duodenojejunal junction, ligament of Treitz. It is characterized by the presence of hematemesis, of vomiting blood, melena, dark, tarry stools, or both. Causes of UGI bleeding can be classified into different categories. Esophageal causes. Esophageal varices. Esophagitis. Esophageal carcinoma. Mallory-Weiss syndrome. Gastroduodenal causes. Erosive gastritis or duodenitis. Stress ulcers. Peptic ulcers, gastric and duodenal. Gastric carcinoma. Miscellaneous causes. Rupture of an aortic aneurysm. Coagulation defects. Angiodysplasia or vascular malformations. Mallory-Weiss syndrome is an uncommon cause of upper GI bleeding. It occurs due to a linear tear in the distal esophagus and proximal stomach, often preceded by forceful retching. Clinical features of upper GI bleeding include hematemesis and/or melena are the most common presenting symptoms. The color of vomitus depends on the duration of blood in the stomach. Bright red blood suggests rapid and significant bleeding, while a coffee ground color indicates a smaller bleed. Melena refers to black, tarry stools and occurs when more than 60 milliliters of blood is lost into the upper gastrointestinal tract. Massive bleeds may result in the passage of frank blood per rectum, hematochezia. In some cases, the presentation may only include symptoms of blood loss, such as dizziness, extreme pallor, shock, angina, or syncope. Features suggesting severe bleeding include presence of clots in the vomitus, fresh blood in the nasogastric aspirate, hematochezia, hypotension and tachycardia, a drop in systolic blood pressure of more than 10 mm of mercury and an increase in pulse rate of more than 20 beats per minute upon changing from a lying to a sitting position. Esophageal varices. Predisposing factors for the development of esophageal varices include large varices, high portal venous pressure, liver failure, use of salicylates, non-steroidal anti-inflammatory drugs, and other medications. Presence of cherry red spots on endoscopy. Diagnosis. Fiberoptic endoscopy performed within 8 hours of the bleeding episode can identify the bleeding site and assess the presence of varices. This is essential to exclude other causes of bleeding. Ultrasonography may be used to confirm the patency of the portal vein. Treatment of acute variceal bleed. General management involves securing intravenous access, monitoring vital signs, intake, output, fluid and electrolyte balance. Resuscitation, with transfusion limited to a hemoglobin level of 7 to 8 g/dl. Administration of acid-suppressing medications such as H2 antagonists or proton pump inhibitors. Vasoconstrictor options include vasopressin, octreotide, somatostatin, terlipressin. Antibiotic prophylaxis with cefotaxime or norfloxacin is recommended. Endoscopic therapy options include endoscopic variceal ligation, endoscopic sclerotherapy. Other interventions may include balloon tamponade using a Sengstaken tube or Minnesota tube, transjugular intrahepatic portosystemic shunt, TPSS. Prevention of recurrent bleeding, secondary prophylaxis. Approximately 65% of patients experience recurrent bleeding within 1 year after the initial bleed. Medical treatment involves the use of non-selective beta blockers, such as propranolol 80 to 160 mg/day, in combination with nitrates. Endoscopic sclerotherapy may be considered if the patient cannot tolerate medical therapy, although it is less effective compared to medical treatment. Endoscopic variceal band ligation, alone or in combination with beta blockers, is another option. Lastly, portal systemic shunt surgery, TAPSS, is reserved for patients who have not responded to medical therapy, endoscopic variceal band ligation, or sclerotherapy. It is performed only in patients with good liver function, Child-Pugh A and B. Thank you for watching. Don't forget to like and subscribe to the channel. See you in the next video.